We all know that grade 3 fatty infiltration and above that doesn't recover well when we do a cuff repair, as said by Gerber and his team. But the pennation angle can be restored well once the muscles start firing and they can, recruit some muscle fibers which are still working. So it is important to, challenge ourselves to, give a good functional shoulder for the patient rather than going in for surgeries where the joint is replaced. Colon's classification is a wonderful classification for all of us. The type C and type D are the challenging ones which we need to remember in our clinical practice to salvage. So what are the indications for SCR? You can see that HLS Bostadius has given us wonderful insight into how a biceps can be preserved for a long time and used as a salvage to manage our massive cuff tears. If the fatty infiltration is 3 and less than 3, we have a functional deltoid, and the Gutierrez classification is good enough, and repairable infraspinatus and subscapularis is an important criteria to look at when we try to do a biceps SCR. So the treatment options are given by my predecessor, Dr. Subramaniam. What are the treatment options for a massive cuff tear, out of which I need to speak on the biceps SCR and how it really helps the patient in clinical scenario. So the first message that Subra gave to you was don't cut the biceps when you see it on the first thing in the scopy. Why we need to do superior capsular reconstruction? It is because of 3 reasons. One is when you preserve the biceps or you add a superior capsular reconstruction, the superior migration of the humeral head is negated, and thereby the elevation of the shoulder becomes much better. The functional abduction force and the passive range of motion of the patient improve dramatically. So as this paper says that it is a useful way to keep the native shoulder for the patient. There are studies to support how this tear patterns or the superior capsular reconstruction helps in augmenting the outcome for this patient. They definitely improve the forward elevation, external rotation, and the acromihumeral distance when done in a good way. And probably these studies have shown that there wouldn't be any graft tear, which is a concern when we use a biceps which is somewhat ragged in a massive cuff tear. Our guys have studied and done a massive meta-analysis of the study where the biceps was used as a SCR. The scores definitely improve. Most of the studies show, but do we say that they will come back to the normal is one that we need to keep in mind. Functionally, they can be restored, but return to sports and all is a challenge in these individuals. This is one of the important papers which was published recently by Bostadius and his group and Dr. Bhatt, which went on to say that the re-tear rates are very less in the infraspinatus, and which is a challenge for us to maintain the force couple when we repair a massive cuff tear. If we do that, and then the functional outcome of these patients will be better. How I do it in my setup? There are myriad of way of doing biceps SCR. You can do tenotomy, you can preserve the transverse humeral ligament, you can do a box pattern. But what I do is, in my setup is this fashion, wherein I do a L shape, preserve the transverse humeral ligament to just keep the pulley there, and then use it to enhance the collagen that is there for the repair. Kim has described it very well. If the audience can go and have a hang of the technical note that they have written, it will be useful for you in your clinical practice. We have done around 10 cases. Rough age was around 62.3 years. Mean follow-up is 18 months. And we have used these following scores. And most of them were grade 3 in Pate's classification, and grade 3 and 4 probably in Gutierrez grade. And Collins classification, most of them are in type C. Most of the scores do improve when we do follow the all the releases and all the preservation of the biology and the tissue augmentation and the co-optation of the tissues, keeping in mind the quality of the bone as well. The results will definitely be better. Allow me to illustrate through this case, who was a 70-year-old lady who was looking after her COVID husband, and she fell down in the house and came to us with the right shoulder pain, with these clinical tests being positive for her. And these are our pre-operative scores. This is a clinical picture. You can see that the left hand, the forward elevation is not great. She is not able to maintain her activities of daily living well, finding it difficulty. The acromial distance is reduced, and Pate grade 3, Guttelier grade 2, and colon 3 was our classification of the MRI scans. Having said that, when we go inside, you will see a picture like this. You don't know where to start. But remember, you need to start intra-articularly release all the capsule, the rotator interval, the supraglenoid releases, tag sutures on the possible cuff tear that you see. Try to find out if you can bring it and to the footprint. If not, try carefully to release between the glenoid, supraglenoid, infraglenoid releases, and make sure that you have enough movement in the cuff before you plan your fixation onto the tuberosity. Biceps is a friend rather than a foe for you in nowadays clinical practice. So keep preserving the biceps as long as possible, because in a day of trouble like this, you can find some relief to get a good cuff coverage on a head which is bald like my head. You can take posterior sutures first and then tag the sutures in this fashion and lock it down. This requires little patience and planning beforehand. Sit the patient down, as Subra was telling, counsel them, and then as you try to do this on the table, do the steps exactly as you planned in your head, and you need to have a good team to support you in doing this. You can see here we are using a ripstop sutures to prevent re-tears in the infraspinatus sutures that we are putting. And you can use the sutures that has been put onto the biceps to tag the infraspinatus as well. Same thing is done with the anterior sutures. As we repair the supraspinatus, the sutures from the biceps are still taken into the supraspinatus in the form of a ripstop, and the lateral row anchors are put. So once we put these in a tension-free situation, you can get a good coverage of the cuff in that fashion. The acromial distance increases once you do this kind of fixation, and this is a follow-up at 6 months. She was diligent enough to follow us up from home with these videos. We were guiding her how to do a physio. You can see the function is improving what she was from before, and she diligently, once the COVID settled down, she came to a physio center and practiced in perturbation, and exercises were followed up at home. And when we saw her recently at a marriage function, and this is how she was from pre-op to post-op. And at the beginning of the first sight when I saw her in a marriage, I was afraid whether I have done a good job for her. And she was grateful for what I have done. And then sometimes it is heartening for you to see a patient like this when you by chance meet her in a function like that. A rehabilitation protocol is followed in this fashion in our setup. Strength building starts in the 3rd post-operative month. Rehabilitation protocol is important because advanced strength training and return to sports in some individuals can be done if they participate well and they are young enough to do sporting event. Advantages are many. Strength and stability of the cuff repair is probably retained. It's a viable supplemental option before we try tendon transfers. It is cheap, and you can really use the forces of the biceps to depress the head and increase the vector to move the shoulder well, and it is cost effective. These are our literature search, and an humble appeal for the next coming elections for the Vice President of the Indian Arthroscopy Society. And on behalf of our team in Bangalore, I invite you all for the Bangalore IISCon, which is there in 2024. Thank you for your patient listening.
Excellent talk.